You will now be placed into the conference.
So my name is Jason Pohl. I'm a scientist with the Pediatric Oncology Group of Ontario, and I sit on the management committee of Sipsey, and I've been leading the Sipsey training program to date. And today's installation of the training program is actually to introduce everyone to some reports that have just started to be generated from Sipsey. And it's really an effort to get data transitioned back into local hands, if you will, so that people can get a better handle on their own data that we pool at the national level. And today we have a number of speakers, and it'll kind of be divided up into 4 parts. So Lillian Sung will give an overview of why we're creating these reports, and today we're going to specifically be talking about one report, which will detail some of the additional reports that are coming. Alicia Randall from the IWK Grace is going to actually walk us through how to actually generate the report from Sipsey itself. And then we're actually going to have a live demo of a report, at which point we'll turn it over to an open conversation about the report itself and other features or data points that people may be interested in seeing. So at this point, we'll get started, and it's my pleasure to introduce you to Dr. Lillian Sung. I think most of us on the call probably know Dr. Sung. So Lillian is a hematologist-oncologist at the Hospital for Sick Children, and she chairs the management committee for Sipsey. And so she's going to start the conversation by talking about the reports today. So Lillian.
Great. Thanks very much for allowing me to give this talk, Jason. So Jason, if you just want to go to the next slide. So this entire exercise around generating reports, to me, the overall goal is to allow institutions, in particular you at your own institution, to access your own Sipsey data for whatever purpose has been allowed by your institution. So if you go to the next slide. So why has this been a problem to date? And I don't know how many of you on the call have tried to access your own Sipsey data. I think the challenge occurs because Sipsey is a relational database, and Jason is going to establish a set of webinars that talks about the relational nature of Sipsey and how to overcome this. But the bottom line, what this means is the data inherent to cancer is a one-to-many relationship. What I mean by that is a patient can have multiple cancers. Every cancer could have multiple treatment plans. Every treatment plan could have multiple chemotherapy agents given, etc. And so this kind of structure where you have one-to-many relationships is called a relational database, and it means that it's hard to put your data onto an Excel sheet, for example, which most people are used to handling. So it means that the Sipsey data exists as many, many, many tables, and these tables are all linked by Sipsey ID numbers. And so in order to use the data, you're going to need some sort of trick or something else to help you link these tables. So for those of you who have received data from Sipsey, many of you have figured out how to use statistical software such as SAS to do this type of linkage. One of the future webinars is going to focus on how you can use a relational database like Access to bring the Sipsey data into one database and how you can link the tables together and create your own flat files. Or we can create flat files to you. And what I'm going to talk about is essentially creating reports or different types of files for you to make it so that you can use your own data easily. So if you go to the next slide, so there are 4 types of reports that we are immediately or in the near future working on delivering to you. The first one has already been built, and that's what we're going to show to you, and that's an institutional report where we can show you numbers of patients, numbers of hospitalizations, and this is set up to report numbers per year. And as I said, we'll go through an actual demo of that. The second type of report that we have asked for and we are starting to develop is a comparative report where you can compare your numbers compared to a national average. So you can know how do you compare compared to everybody else. Third type of report that we've also started to work on is an individual patient report, so that you can pull up Johnny Smith, and you can see Johnny Smith was diagnosed with ALL on December 1st, that Johnny Smith was enrolled on AALL 0932, that he's received this much anthracycline, that he did not receive radiotherapy, and that he had these types of complications. And one of our hopes is that the individual report can ultimately lead to a survivorship passport, where we can create a 1- or 2-page summary that you can provide to patients and families that summarizes that patient's journey. And then finally, what we hope to be able to generate for you in the near future is a raw data flat file where it is one diagnosis per row of the most common types of data elements, which would be date the child presents to the healthcare institution, the date they're diagnosed, their diagnosis, the location of their tumor, their treatment plans, and their outcomes as examples of elements. So the top one, institution by year, has been created. The next 3 are in some process of development. The key thing for me to emphasize is that all of these reports are very amenable to feedback. We want to create these reports in a way that's most useful to you. So we're very open to feedback and to changing these reports and to creating different formats according to your needs. Next slide. So what we're going to talk about today is the institutional report, and as I said, the version that we're going to show you is just a first draft. We are very open to modifications. Alicia's going to walk you through how to generate it, and I'm going to show you what it looks like. But just in thinking through this institutional report, how might you use this type of data? You might use it just to understand what happens at your own institution, get a sense of workload, get a sense of outcomes. One very useful purpose for this report could be data checking and quality control, and I'll show you examples in the report that we're going to generate. And then third, you might use it to understand whether specific research projects are feasible. So it will tell you, for example, the number of patients with Lee-Fraumeni that you have at your institution. So that might be able to tell you, could I do a study with Lee-Fraumeni, either using Sipsey data or perhaps a future prospective study? How many children with Ewing sarcoma do you see? How many children with a specific type of translocation, a specific type of ALL translocation? So you'll be able to look at those types of data and understand what is possible for you to do as a single institution. So that's the intro. I'll hand this over to Alicia now.
Great. So now we have Alicia Randall, who's one of our data managers at the IWK Hospital. She also sits on the management committee. So Alicia.
Hi, hi everyone. I'm happy to just give you a quick overview of how to access your reports. So the first slide here is what you'll see after you log into the Sipsey database. So when you log in, you'll see this screen, and at the top there's a reports function there. You click on to that. It will bring you to the next page in the database. And it gives you a list of types of reports you can generate. And the one that we're specifically looking at today is the annual statistics at the bottom. And once you click onto that, it brings you to the next page. And basically, you can select the time frame for the report you want to generate. So if you include all dates, it'll run all of your data, so from 2001 till where you currently are. Or you can select year by year, or you can select a 5-year period, whatever you desire. So when you do enter the year in, it goes day, month, year, and the month has to be written in as January or February, the 3 letters. And once you select that, you click View, and it might take a few minutes to generate, depending how much data you're looking to look at. And so it'll open up the report. And this screenshot is the top part of the file. So you'll be able to see all your data, and there'll be a number of pages that you can kind of scroll through to take a peek at what's there. If you select multiple years, it'll kind of give you columns. So it'll total all the years, and then it'll divide everything out. So it'll give you 2010, 11, 12, 13, 14, and so forth there. So you can look at the file in that way. The other thing you can do is you can save the file. So in order to do that, you have to click on the top of the screen. There's a little kind of save button, and it will export the data. When you click that, it'll drop down, and what you want to do is export it to an Excel file, which is the most kind of compatible file that this will work with. Once you click that, it will ask you if you want to open and save. So what you do is you click the open, and then it'll open up Excel, and it'll give you a couple different sheets with all of your data. Basically looks the same as it does in the report, but you can then save it or print it and those kind of things. Other than that, it's fairly easy to access. You have to be an administrator of the database to be able to access the reports. So you'd have to know who that person is at your site, and then you have to have certain permissions to access the report as well. I think that's all I'd like to say to do that.
Great. So thank you, Lisa. Sorry?
Can I just ask, if people don't know who their administrator is, how do you recommend people figuring out who that person is? That question's for you, Jason.
The question's for me. So there's a principal investigator located at each of the Sipsey sites, and the principal investigator essentially is the person who ultimately controls, who has administrative access. So the data abstractors at each of those sites have that administrative access, as do some of the PIs. If you're having a hard time identifying who the PI is at your site, the best person to email is Randy Barber, who is the one who sends out the invitations for this talks. He will be able to identify who you should be in contact with at each of the centers.
And Jason, can I just ask, to get the Ontario data, does that go through POGO, and do we have to go through POGO, or does that come through our individual sites?
So you're right. So this is a good question coming from Ontario. So POGO feeds the Ontario data to Sipsey, but because the sites themselves in Ontario don't use Sipsey to capture the data, there are parallel reports that are being generated in Pagonis. So eventually Pagonis will be able to generate similar reports at the local level for people.
But in the meantime, we don't have access to that.
So in the meantime, you don't have the POGO sites, the Ontario sites don't have access to this, you're correct. So if you need the data, you can make a data request to POGO and we'll fill it, but the actual automated reports are in the process of being developed and deployed in Ontario.
And then my second question was about the survivorship care plan reports. Is that likewise going to come through in this way and be managed this way, or is that going to be aligned with the POGO program, or what do you guys envision for that?
So in terms of survivorship care, I think it's a separate database here held at POGO, and the survivorship care is in some ways limited in Sipsey in the sense that Sipsey only tracks people for 5 years from their date of diagnosis. So if we're talking about Sipsey, the 5 years from date of diagnosis will be available in various reports, and we can certainly add some elements to these annual statistic reports if that's of interest to people, and we'll talk about that in the open discussion, I think. In Ontario, it's a slightly different process, and I'm not sure exactly how POGO is going to tackle that at this point.
Thank you.
Jason, can I ask you the timeline for Ontario to generate, I think it's fabulous that POGO is going to do that, but what's the timeline for institutional reports, do you think?
So I actually right now don't know the exact timeline, but I know that the medical director and the Pagonis team here have met with the division chiefs at each of the centers to discuss this. And so a draft report was generated, and I think we're just waiting on feedback, and then ultimately it'll get deployed. So I think we're just in the process of finalizing exactly what the report would look like, and then the deployment portion.
That's great. Thank you.
So now I think we'll move to an actual example of what the center reports look like. So now on your screen you should see essentially an Excel spreadsheet that Alicia basically described how you would actually save. So this is a mock one, if you will, but this is essentially what it would look like. And I think Lillian is going to walk people through exactly what you see in this report. The only thing that I'll point out maybe at the beginning is that actually you'll see up at the top corner we have requested this report from 2001 to 2018, but in actual fact I've just, for demonstration purposes, I've actually just hidden the cells for the other years. So Lillian.
Great, thanks. Jason, I'm going to ask you to highlight things with your pointer as I talk about them. So as Jason said that you will start off by specifying the years that you want. So in this report we specified a long time. You probably won't want that many years, and that's that step that Alicia described when you put in the range of years that you want the report for. What you will see in this report is 4 tabs at the bottom. So they're not actually labeled, but sheet 1, 2, 3, and 4. Sheet 1 and 2 have the diagnoses lumped in main categories as leukemia, lymphoma, solid tumors, and CNS tumors. And sheets 3 and 4, which we'll get to later, have the same types of information but described for each diagnosis type, more specific diagnosis. So we start with the top set of statistics. So this first sheet, sheet 1, deals with all yes, no type of data, so binary data. So did you have leukemia, did you have lymphoma, did you have cancer, did you have a solid tumor, and did you have CNS tumor? And this gives you a number. So the first set of statistics is around the number of diagnoses. As I said, all diagnoses and then stratified by type of diagnosis. For this institution, you can see that from 2001 to 2018, there are 242 cancer diagnoses entered in the Sipsey database. And then you see it split up for 2013, 2012, 2011, and 2010. And so you can see that what's probably happening here is that there is some variation year to year. Now that could be true variation in that 2012 has more diagnoses than 2013. That could be true variation, or it might be just 2013's behind. And that's an example about how you might be able to use this data for quality control and seeing where you are in terms of data entry. And then you see how those diagnoses are split up. So you'll see that for 2013, for example, 66% of the diagnoses are leukemia, 20% are lymphoma, 11% are solid tumors, and 3% are CNS tumors. So that's the probably the most common type of data you're going to want to refer to, just what is your incidence numbers. So if you go to the second set of statistics, so the next gray box, you'll see it's entitled Primary Diagnoses Registered on a Clinical Trial. So the intent of this statistic is to give you a sense of how many of your patients are being enrolled on a clinical trial for their first treatment plan, which is what we're normally describing. And you might be interested to know that we describe this number for all of Canada in one of our Sipsey reports, and that number is around 25%, which is not surprising, but much lower than what most people would think. So if you look at this particular report, the way it's structured is if you look at the 2013 number, what you can see is that there were 3 patients who were diagnosed in 2013 that were registered on a clinical trial. So it's important to understand this number. It's 3 patients who were diagnosed in 2013. It's not that there were 3 patients that were registered in 2013. So this gives you a sense of the proportion of patients that were diagnosed in 2013 that were registered on a clinical trial. So I hope that distinction is clear. So what this says is that 12% of patients with leukemia who were diagnosed in 2013 were registered on a clinical trial. And then 0% on lymphoma, solid tumors, and CNS tumors. Now, this could be lagging data or this could be real, and that would be important for institutions to check to see whether or not that made sense. So if you go down to the next set of numbers, what you see is the number of relapse. And again here, the number that we're showing you is the proportion of patients diagnosed in a specific year who have relapsed. So in this exact example, what you can see is of the 36 patients diagnosed in 2013, 1 is documented to have relapsed. So that gives you a crude relapse rate. It's not exact because it's not using survival methods, but gives you a sense of what your outcomes are like. And what you can see is that 1 patient who was known to have relapsed is a lymphoma patient. So if you go down, deaths work exactly the same way. So these are the number of deaths amongst patients diagnosed in that year. So if you look in 2013, amongst patients that were diagnosed in 2013, 5 are known to have died, which gives you a crude mortality rate of 13%. Again, it's not exactly right because we're not censoring properly, but gives you a rough idea of what your outcomes look like. And obviously, as time goes by, that proportion is going to increase because you'll allow more time for patients to pass away. And then if you go down to the last set of numbers here, hospitalizations does work differently. This tells you the number of hospitalizations in that year. So this one isn't related to patients diagnosed in that year. So what this tells you that in 2013, this site had 45 hospitalizations for all of their patients. So that's the first sheet, that sheet 1, that deals with all yes-no variables and groups diagnoses into these major headings. If you go to sheet 2, sheet 2 also lumps diagnoses into major headings, but here we're looking at continuous outcomes. And this is where I think the data will be really useful for data managers for quality control purposes to identify likely errors in the database. And in my own research program, we do this a lot to identify data entry errors. So we just look at the, let's just start with 2013 and looking at age at diagnosis, because this one is a good example. So what you can see, oh, no, go up. So if you look at 2013, the first set of statistics are around the median age of diagnosis and the range, so the middle value. So this says that the median age at diagnosis for this institution's cancer cohort is 4 years of age. The median age for the leukemia cohort is 7. The median age for the lymphoma cohort is 4, and so on. The range is particularly helpful. So this is the youngest patient registered and the oldest patient registered. So you shouldn't probably have a 33-year-old patient registered. So that tells you that there's probably something wrong with that data entry or a glitch in our report. Either way, we need to fix it no matter what. And so the same will hold true for 2012, 2011, 2010. And if you look at all years, the range again tells you that there's a 47-year-old patient somewhere in this data set, and that's probably incorrect. So if you go down to the next set of numbers, what this is days from the date first seen at the healthcare institution for the symptoms that led to the diagnosis of cancer to the diagnosis. So it's some time to diagnosis measure. This can give you a sense of your time to diagnosis or that lag time. Here, I think the median values often make sense, but the ranges clearly are showing some glitches. And the ranges, as I said, will be really useful to data managers to help clean up the data and make sure that data set looks okay. If you go down to 2015, most of the data look fine. So a median of 4 days is actually pretty reasonable time from time you're first seen in your healthcare institution to diagnosis. Recall that your date of diagnosis is defined as the date the procedure was performed that led to your diagnosis. The range is actually pretty reasonable too, the range of 1 to 38 days. So that's what that row means. If you go down to the next row, days diagnosis to treatment, so the next gray line, this is very similar. So this is the time from the date you were diagnosed to the date you started your first cancer therapy. For brain tumors, that number will often be 0 because your first cancer therapy will often be the surgery that led to the diagnosis. For leukemia, that time, or ALL and AML actually, the time interval is typically very short. In Stacey's study in Ontario, I think it was, I don't remember now, 2 days, something like that. That was your study, right, Stacey? Maybe I'm getting that mixed up, possibly.
That one wasn't mine.
Sorry, I'm mixing up studies now. Okay.
Yes, things with similar people.
Right. So at any rate, so that's what that measure is. And then if you go down to the last measure, it's just your average, your median duration of hospitalizations in that year. So that gives you a sense of how long are your patients staying in and gives you a sense of how does that vary by underlying diagnosis. So if you go to sheet 3, sheet 3 is exactly like sheet 1, except for now you see it split up into specific diagnoses. So the leukemia split up into ALL, AML, and other leukemias, lymphomas, Burkitt's, and mature B-cell lymphoma, Hodgkin's, non-Hodgkin's, and other, and so on. And so that might be particularly helpful to peruse the data to make sure it makes sense to you, and then helpful to you as you start to think about feasibility for research studies and giving you a sense of your burden of a particular diagnosis type. And then sheet 4 is exactly the same as sheet 2, but for continuous variables. So that's how these institutional reports work. These are live at each of the non-Ontario institutions. If there are glitches with our program, and there might be, we definitely need to know about them and fix them. But we would really like to work with you, but I think accessing the data would be of interest to most of you on the call. I would ask that you check with your institutional PI to make sure that you can access the data, and I'm sure the administrative assistant at each, administrator at each institution will need to do that anyways, but just to make sure that the institutional PI is aware that you're looking at these reports, because they ultimately have the ability to decide who can see them. So that's really what we wanted to show you. Again, these are all just initial drafts. What we've already heard is that what I showed you is that the statistics around relapse and death relate to the number of patients diagnosed in a year that relapse and die. We've heard that there's also interest in knowing how many patients relapse and die in a certain year, and we will certainly create that or add that to the report. That will be very straightforward to add with just very different interpretations, right? So the number of relapses and deaths give you a sense of workload for your institution and burden, whereas the number of relapses and deaths amongst those diagnosed in a year gives you a sense of what your own cancer-related outcomes are. So are there any more slides, Jason, or is there anything else you wanted to add?
No, that was it in terms of slides. The one thing I will say is that given the reports are generated in Excel, as I'm clicking on this, you'll notice that the numbers are stored in individual cells, which does allow a fair bit of flexibility even at the institutional level to be able to add or subtract or divide these numbers in various ways. So hopefully that will give people some added flexibility. They're not when you save them as Excel, they're not just snapshots that you have to retype or whatever. The numbers are there for you to use. So I think this portion now is just really to have a conversation about what people think about the institutional reports or any questions they have, any highlights in terms of additional data points that people might be interested in the long term. And I think really the conversation is about, you know, what would the majority of people like. I mean, if it's an individual data request for a particular study question that you're trying to answer, then I think that that's more of an individual data request that can be filled. But really this is to give people an overall view of what is happening at their institution. So at this point we'll open up the floor and allow people to ask any questions with regard to the institutional report.
I wonder if we could give Sam 5 minutes to talk a little bit about the work Sam's been doing at the IWK. Sam, would you like to introduce yourself to the group? I don't know enough about your background to do it justice.
Okay. My name's Sam Stewart. I'm a professor of medical informatics in the Department of Community Health and Epidemiology at Dalhousie. And I became involved in this project a long time ago, during my PhD studies with Mark Bernstein, looking at developing our own reports. So it started first as wanting to develop some sort of passport system, and then we looked at developing some survival reports, some individual patient reports, a number of things, and it's continued on that with some, failed grant applications. But what I'm kind of interested in now is just how easy it is for us to create our own reports. So, like these annual statistics are good, and I like the sound of a lot of what you're proposing. But as you said, ultimately underneath is a fairly complex relational database that it's really kind of hard to build a data cube system where people could select their own input. So ultimately, I think the best data extraction happens at the database level rather than at the Sipsey portal level. In terms of the work we've done, we've got another problem we've had is a matter of getting the reports that we produce into the Sipsey portal. That's just a matter of liaising with DAPAsoft and finding the best solution so that if we develop a survival analysis or a wait time report, how we can get it into the system to be generated on a semi-monthly or semi-annually time period.
Sam, I think we can speak to a couple of those things. Lillian can certainly chime in. I think in terms of, I think the IWK has been pushing forward on this much faster than many of the other institutions, which is fantastic. And I think if there is or are reports that you guys have generated that would be of interest, you think, to the wider community, I think there's an opportunity to bring them to the management committee to basically review those reports and then make a decision, and ultimately then the management committee would work with DAPAsoft to see them implemented in a timely and an appropriate way. So I think there is an ability actually to add additional reports as people see the need for them. And I mean, you guys the IWK is in a very unique position because they have you to be able to sort of help with the legwork, if you will, in generating these things. But I think the management committee itself is also interested in having people come forward and say, actually, I want a survival curve of my patients that I can stratify by particular years or summarize, say, over a 5-year period by specific diagnosis. And so we can then, if that's the idea, we can actually work in terms of the background and doing the legwork to actually figure out how to generate it. So I think it can happen in both ways, but I think channeling most of this through the management committee is probably the most appropriate way. Lillian?
Okay, that's great.
Yeah, no, I agree completely. And I wonder if this is an opportune time for Jay, if you feel okay to do this, to talk a little bit about the data cubes, because I think that is something that will impact not at the institutional level, but at the overall Sipsey level. I think it'll be a really positive step forward.
Yeah, for sure. So I guess the plan with respect to the data cubes, or our new terminology for them is data tools, we have a number of these hosted right now on the Public Health Agency of Canada's Infobase website. And essentially the plan here is to take the tables and figures that are currently presented in Sipsey's first surveillance report and make those tables and figures or tables and figures along those lines available online in that tool. So I think it would be the kind of thing that would give that sort of good global overview in terms of what's happening by condition, against these kinds of measures. And it would certainly make sense that there be some, very close and practical crosswalk between this tool, your tool here, and our data tools online. So I think that's something we'll have to look at as we move into the closer to the production of that tool.
So questions about any of this? Has anybody attempted to access their own data yet?
No. I have.
You have?
I just
and what? Oh, okay. You don't count, Sam.
I mean, I think as Lillian pointed out at the beginning, these kind of reports will be very helpful probably at the divisional level and for individual clinicians at each institution to know they're available to basically even track, or for data quality in particular, to know what it looks like for the patient population that you're trying to manage. So we're hoping that more people will be able to access them in the near future.
So we're really committed to getting your data to you. If you're having trouble, please reach out to any one of us. We're really happy to help problem solve. If people would like us to push a specific report that you think is more useful, we can't flip back and forth priorities, but we'd like to hear from you what you want and what is more helpful.
Hi, Lillian, it's Tony here.
Hi, Tony.
Hey, sorry, I instead of hitting unmute, I hit the speaker and I hung up and then I called back in. So I'm asking a question that's already been asked already. You know, the report right now, I think it's a great start. It's really a flat file that allows you to look at things in aggregate form, and some of it's broken down, like you showed in the separate pages, by cancer diagnoses. I think, and everyone is on the call has kind of alluded to this already, but what individual institutions really want to do is a way to just make a query with maybe 3 or 4 different variables. So, for example, the number of patients with Ewing sarcoma that undergo surgery that have X complication or something like that. And I know that's kind of in the works for the future, but how complicated would that be, and at what point do we think that would be realized? Like, how close is this to what we are having right now?
Yeah, I think that's a great question, Tony. So I think it depends on what you mean by how close are we to have that realized. I think that one of the good things about the flat file, so the flat file again is this idea of one diagnosis per row with what we think are the most important data elements across the top. So there are going to be things like date of diagnosis, date of death, date of relapse, treatment plan, whatever. And so diagnosis will absolutely has to be one of those columns. Once you have the flat file, you can just do anything, right? You can sort, you can filter. So I think the fast way to get at your question of how many patients do I have with Ewing sarcoma, how many patients do I have that are less than 1 year of age at diagnosis, will be very possible to do in Excel with minimal Excel manipulation skills. The next level up would be to do that in Access, and that's what Jason's in the process of arranging, some instructional video about how you would do that. That, I think, is actually very close as well, and then you could create a query in Access to do all of what you're asking for. I think pre-made queries are probably a bit farther away. I think being able to pull the data into Access is available now. I think a web-based format where you can say, I want to know how many patients have Ewing sarcoma that are 2 to 8 years of age, that is not in the near future, at least not that I can see. I think we need to focus on the lower hanging fruit to get to your data first. And then that more sophisticated queries would be some later initiative. Does that answer your question, Tony?
Yeah, yeah, I totally agree with all that too. I think what's a great point to start with is to give the institutions the flat file. No, the report that you showed, I think, is different from what you're referring to, where you can put filters on the headings and then just filter one by one the columns that you're interested in. Is that going to be available at some point for the institutions to download a flat file like that?
Yeah, so that flat file is up for, if you go back, Jason? Can you go back on your, keep going, right, go forward one.
Forward one.
That one. So this raw data flat file is the file that I'm talking about, Tony, that you can filter. The filter is just a simple Excel tool, right? So once we have that raw data flat file, you'll be able to do that kind of filtering. I don't know if Randy is on the call. It says you're on the call. I don't know if you really are on the call. I'm going to take a guesstimate. That could be completely wrong, but I'm going to guesstimate we're 3 to 4 months away from that. In other words, not tomorrow, but not a year either. So I think that is achievable in the nearer future.
Okay, great. Thank you.
Yeah, I think, Lillian, just to add to that, I think, you know, where we are in that process is we've actually outlined what we think the specifications are for that flat file. So we're in the process of trying to have that programmed at this point. So it just takes a while for, you know, data quality to go through and make sure that the generation of it is working. But we have some specifications for the flat file already.
And I think DataSoft actually already has it, I think.
Yeah, no, I think they're working on it. So as Lillian points out, it's in the relatively near future. So, other questions or comments about the institutional reports or reporting in general from Sipsey? All right, well, hearing none, I just would like to thank Lillian Sung and Alicia for presenting today and showing us how we can access these reports and what the reports look like. And I guess just to tell everyone, thank you for coming, and hopefully you'll be on the lookout for these reports at your institution and figuring out how you'll be able to access them. Just to remind people, if you are interested in trying to access these reports and you don't know who to contact, the best person to contact is Randy Barber, and he subsequently will let you know who the contact is at your center. So again, thank you everyone for coming, and we look forward to the next installation of the Research Champion webinar series. Thank you.
Thanks, Jason. Bye.
Thank you.
Thank you.